I call the meeting to order, and because of the time, we're going to skip introductions. It's Wednesday, by the way, it's Wednesday, January 15th, and our time is 1:28 p.m. We're going to begin our Health, Finance, and Policy Work Group. And with that, because we're skipping introductions, we will turn it over to our fine nonpartisan walkthrough. And they've spent a lot of time. We have a lot of responsibility in this chair, in this committee, excuse me, for the health of Minnesotans. And we've met with them, myself, Mr. Carter, and Representative Vice Chair Nadeau several times. And so we decided this is very important to get this information. So with that, we are going to turn it over to Mr. Joe Harving, and we'll let you guys begin.
Representative Backer, members, today we will be providing an overview of some select accounts and information within this committee. A bit of an outline. We'll do just a quick run through of nonpartisan staff roles, overview of the budget, talk about subsidized healthcare programs, MNsure, the regulation of health-related occupations, MDH, Office of Emergency Medical Services, and the Rare Disease Advisory Council. But first things first, I'll kick it to Ms. Clarkvis and Ms. Mock to talk about the House Research Department.
And then if I may interrupt, you have a packet, if you haven't found that, that is in your information, and of course on the screen, members. Thank you.
Representative Becker, I will just run through quickly the nonpartisan staff roles. So you have the House Research Department. Ms. Clarkvis is to my right and Ms. Mock is to my left. They're generally responsible for drafting bills and amendments, writing bill summaries, providing background research on topics, and answering questions on bill content and legal consequences. Myself, I'm with House Fiscal. We generally track revenue and budget effects of legislative and executive policy goals. We interpret and analyze revenue estimates for fiscal notes, and we also offer confidential fiscal analysis of spending, revenue, policy, proposals, etc. To get into the budget overview, I'm gonna just provide some quick budget basics with the words you'll about to see. So you of course have the general fund. Another account this committee regularly interacts with is the state government special revenue fund. That account is established to account for a number of mostly health-related special revenue accounts. The revenues in these accounts are normally not specifically dedicated, and spending from these accounts is generally authorized by a direct appropriation by this committee. The next two accounts, restricted miscellaneous special revenue and other miscellaneous special revenue, is largely a distinction among generally accepted accounting principles, but do know that restricted is self-evident. Proceeds of a specific revenue source that are legally restricted must be restricted to an expenditure for a specific purpose. Other miscellaneous special revenue is for accounts that are dedicated but for a variety of specific purposes. The federal fund, for brevity, is all federal dollars that aren't for temporary assistance for needy families, otherwise known as TANF, and federal TANF is the fund for that, is the federal block grant that provides states with resources for low-income families, family home visiting, WIC, teen pregnancy, etc. You have the Healthcare Access Fund. The Healthcare Access Fund is largely funded by the provider tax. More on that later. Its intended effect in statute is to increase access to healthcare, contain costs, and improve services for Minnesotans. You have also the remediation account. This is a source of public dollars for response and corrective actions to address the release of hazardous substances, pollutants, and other contaminants. And then you lastly have the Drinking Water Revolving Fund, which provides below market rate loans for public water system improvements. So the overview of topics and accounts that we were asked to present on today are on the slide before you. At the Department of Human Services, that is medical assistance, Medicaid, otherwise known as adults with children, without children basic care, medical assistance families with children basic care. You have Minnesota Care and other health care grants at DHS. Also the entirety of the Health Department, Office of Emergency Medical Services, 16 health-related boards, MNsure, and the Rare Disease Advisory Council. To give you a broad look at what that looks like, those topics look like in terms of general fund base spending, it is considerable, a large chunk of which is taken up by medical assistance. So Medical assistance alone accounts for $4 billion of general fund spend within this committee's account list. I will note that MDH, while a smaller sliver of this, but for being included with medical assistance on the slide, would be probably the 7th or 8th largest agency in the state of Minnesota as far as general fund dollars goes. So do know that while the scale looks off, that it's still a considerable amount of state resources devoted. I mentioned the Healthcare Access Fund, and it's worth pausing now for a little bit to talk about this. Not one single committee owns the Healthcare Access Fund, but primarily this committee is the committee that deals with those issues. So it's funded mostly by the provider tax. That is an imposition of gross revenues, taxes on various types of providers of healthcare goods and services. Those revenues are deposited into the Healthcare Access Fund and used to pay for portions of medical assistance and Minnesota Care. In your packets is a spreadsheet that is titled at the top, Healthcare Access Fund November 2024 Forecast, with a date and time of January 14th, 2025 at 3 p.m. In this spreadsheet, you see also that the fund pays for various agency responsibilities, including the administration of Minnesota Care, and for granting a variety of other resources that have the intended effect of enhancing public health activities. Who gets taxed by the provider tax? Healthcare providers. That includes licensed healthcare professionals, such as physicians, dentists, nurses, psychologists, physical therapists, chiropractors, individuals providing services reimbursed under Medicaid, model health plan companies, an HMO where services are provided by employees, ambulance services, opticians, and sellers of hearing aids. You also have hospitals, surgical centers, and wholesale drugs distributors subject to this tax. The tax rate for calendar year 24, the tax rate is 1.8%. The rate may be reduced from year to year by the Commissioner of Management and Budget in consultation with the Commissioner of Revenue based on a balancing calculation in the Healthcare Access Fund from revenues to expenditures. That happened once in recent memory in 2023 when the rate was reduced to 1.6. But otherwise, since 2020, I believe, the rate's been 1.8. On the spreadsheet, you also, it's worth noting, there's the gross premium tax. This is a tax imposed on all HMOs, nonprofit health service plan corporations, and community integrated service networks. They must pay a 1% tax of gross premiums to be deposited into the account. Amount of revenue collected in 2024, the provider tax yielded $751 million. And the current estimate under the forecast is that the taxes will yield approximately $824 million in fiscal year 25. Current projections for the upcoming biennium is that the tax will yield $860 million in 26 and $902 million in 27, fiscal year 27. And I mentioned sort of the other sources of revenues. And again, stressing that there's information on the slides I'm about to show you, but there's also the statement itself. It should be in your packets. Again, to visualize this for you, this just is the a slide on the forecast expenditures following the November forecast. A huge chunk of it does go to the medical assistance program with the corresponding estimate of the federal BHP expenditures there. Again, just a visualization for you of the revenues. Like I said, I spent a lot of time on the provider tax because that is just what the main source of revenue to the fund is. I'll note on the far right of this illustration is the BHP revenue. That's mostly illustrative. There's little the state can do with that. It's a one-to-one. You get federal BHP dollars and you spend federal BHP dollars. It's in a trust fund. The legislature's ability to interact with those dollars is limited at best. That does it for sort of healthcare access fund and general fund. I mentioned at the outset that another topic is other healthcare grants at DHS. This receives a huge chunk of federal funding, approximately $132 million, with approximately $15 million split between the general and healthcare access fund from the state. Some of the other healthcare grants here include in-person assister and Minnesota community application agent programs. This includes emergency medical assistance. This includes immunization registry grants, child and teen checkup grants, integrated care for high-risk pregnancies, and periodic data matching grants. The particular set of healthcare grants in this budget activity can change over time depending on the length or the funding of the project. And the grantees can range from providers, counties, community-based organizations, et cetera. And with that, I'll end on healthcare grants and turn it over to Ms. Mock we will begin talking about subsidized healthcare plan programs. I will just show you again a illustration of the medical assistance funding. There is also medical assistance in human services finance. This committee has approximately 24 to 25% of medical assistance funding within it. The other committee has the remaining 75%, composed of long-term care waivers, long-term care facilities, elderly basic care, et cetera. All in medical assistance base amount, all funds, is approximately $6.3 billion in the upcoming biennium. And just to round this out, as before Ms. Mock gets going, Minnesota Care receives considerable federal funding, and this sort of shows that dynamic with $1.1 billion due to the state this upcoming biennium, with approximately $259 million coming out of the Healthcare Access Fund. And with that, Ms. Mock will get more into the details.
Hello, that's on. All right, I'm Annie Mock with House Research. And I'm going to talk a little bit about specifically medical assistance, or MA, and Minnesota Care. But before I get into the details of those programs, I just want to talk a little bit about where they sit in the continuum of subsidized coverage that's available to low-income Minnesotans. So on the left side of the slide, you see the medical assistance program, which is, of course, the state's Medicaid program that pays for health care for low-income families and adults without children. Each month, there's about just over 1 million people enrolled in medical assistance. And you can see there's as Joe just went over, there's a considerable amount of federal dollars that come into the state for medical assistance, as well as the state puts up money, and counties do too. Minnesota Care is another program that is a federal state program. It's not the Medicaid program. It is a basic health program, which is a type of program that was established under the Affordable Care Act. This program is also to help pay for the coverage for low-income individuals, but these are individuals who are specifically not eligible for medical assistance. It is a significantly smaller program than MA. There's only about 100,000 people enrolled in Minnesota Care each month. And as you can expect with that, there are smaller amounts of federal dollars and state dollars that go toward the program. Finally, just to round out this continuum of subsidized coverage, I'm just going to briefly mention the premium tax credits and cost-sharing subsidies that are available through MNsure to individuals who may have trouble paying for healthcare coverage but are not eligible for either MA or Minnesota Care. So these premium tax credits and cost-sharing subsidies are available to some individuals when they purchase coverage through the exchange, but they are completely federally administered and federally funded, so I will not be talking about them any further. All right, so to focus a little bit on MA, to be eligible for MA, an individual has to be a Minnesota resident. They have to be a citizen or legally present or a legal non-citizen. They have to belong to an eligible group, and they have to meet associated income and asset limits. So we can go to the next slide. So these are the different eligibility groups at a high level for MA, and you can see their associated income limits and asset limits. There's a line in the middle of the table. The 6 groups that are above the line are eligibility groups that are typically under the Health Committee's jurisdiction. The 3 groups that are underneath the line are eligibility groups that are typically under the Human Services Committee's jurisdiction. And Joe touched on that a little bit when he was talking. Go on to the next. There are a number of covered services under medical assistance. It's a fairly comprehensive benefit package. There are a number of services that are federally mandated, as well as there are services that are optional at the federal level, which means states can choose to cover them. If they do, the state gets the federal match for covering those services. Minnesota covers most optional services that are available. This is the only statutory citation I have in my slides because it's an important one. This is where 256B.0625 is where you'll find most information about covered services and how they're covered under MA. As for premiums and cost sharing, there aren't any under MA. So MA does not charge any premiums, and as of January 1st of last year, there isn't any cost sharing required under MA either. So there are two primary ways that services are delivered under MA. One is through managed care and the other is through fee-for-service. Most MA enrollees are enrolled in managed care. I think it's about 75% of MA enrollees each month are covered under managed care. So they are covered under HMOs or county-based purchasing plans that contract with DHS. There are certain individuals who are required to enroll in managed care. Those include families and children, adults without children, and individuals age 65 and older. As for the fee-for-service system, individuals with disabilities may opt out of managed care and instead enroll through fee-for-service. So just very briefly on how managed care works. So DHS contracts with HMOs or county-based purchasing plans to provide service to MA enrollees. Those MCOs or managed care organizations then receive a capitated payment from DHS for each MA enrollee. And then they're expected to provide all the covered services to the MA enrollees. And then the MCOs are the ones who actually negotiate with the healthcare providers as to how much the healthcare providers will be paid for the services provided. It's a little bit different for fee-for-service. For fee-for-service, the enrollees, MA enrollees actually receive care from any participating provider in MA. Then those providers bill DHS directly for the services provided, and then DHS reimburses those providers according to a large number of rules that are in statute and sub-regulatory guidance. So just quickly, an overview of who MA enrollees are. You can see on the left side of the slide that most MA enrollees are parents and children, 63% of the enrollees. A smaller amount have a disability or blindness. Only about 6% are age 65 or older, and about 22% of the MA enrollees are adults without children. If you look on the right side of the slide, you can see how MA spending breaks down for each of those categories. So for parents and children, only 24% of MA spending is on those individuals. In comparison, about 40% of MA spending is on the 9% of enrollees who are disabled or are blind. About 20% of spending is on the individuals who are 65 or older, and about 17% of spending is on adults without children. And Joe went over this a little bit, but MA is jointly financed by the state and the federal governments. It is also an entitlement program, meaning that anyone who is eligible is guaranteed to receive services. States receive federal matching dollars for providing those qualified services to eligible enrollees. So the federal share, the federal medical assistance percentage, or FMAP, is determined by a formula that's in federal law that's based on per capita income. So states with higher per capita incomes receive lower federal matches and vice versa. You can see for Minnesota the various federal matches there at the bottom of the slide. All right, so I will move on to Minnesota Care. Kind of go through the same things. You're probably going to hear me say a lot of the same things, but as they apply to Minnesota Care. So to be eligible for Minnesota Care, an individual has to be a Minnesota resident. They can't have access to any other health insurance coverage, including MA. And they have to meet certain income limits, which is to have income greater than 133% of the federal poverty level, up to 200%. You'll notice on this slide there isn't a citizenship requirement as there was for MA. As of January 1st of this year, there isn't a citizenship requirement in place for Minnesota Care. Minnesota Care covers most of the same services that MA covers. It covers more of those services for pregnant women and children than it does for adults who are not pregnant, but the benefit packages look very similar in the two programs. There are premiums for Minnesota Care. They only apply to enrollees who are age 21 and older. They're per person monthly premiums, and they're based on a sliding scale. Currently, that sliding scale goes from $0 to $28, but in 2026, it'll increase, the range will increase from $0 to $80. And that just has to do with the fact that under a federal basic health plan, premiums can't be any more for individuals enrolled in the plan than what they would have to pay if they were receiving a premium tax credit through the exchange. And right now, under federal law, the premium tax credits that are available are increased more than they have been in previous years. And so the range of premiums that can be charged to BHP enrollees is smaller. But those increased federal premium tax credits are set to expire at the end of 2025. You can see there on the slide that some enrollees are exempt from paying premiums. There's also cost-sharing requirements in Minnesota Care. They vary by service and enrollee. But in general, DHS is required to adjust all the cost-sharing requirements to maintain an actuarial value for the plan of 94%. And you can see there again on the slide that, just like for premiums, some enrollees are exempt from cost-sharing requirements. Most Minnesota Care enrollees, and nearly all really, are enrolled in managed care organizations. So similar to how it is for MA, DHS contracts with health plans to become MCOs, and then they receive a capitated payment for each enrollee enrolled in their plan. And then the provider reimbursement rates under that plan are negotiated between the MCO and the healthcare providers. And Minnesota Care has to offer at least 2 MCOs in each county. Finally, just a note on financing for Minnesota Care. So there's both federal and state funding for Minnesota Care, as Joe discussed. For federally eligible enrollees, the program is jointly financed, so the federal money and the state money flows for those enrollees. But for any enrollees who are not federally eligible, so this would be individuals, for example, who do not meet the citizenship requirements that apply to the federal basic health program. For those enrollees, the program is financed only by the state. And the state receives, the federal funding, the state receives federal pass-through funding in terms of 95% of the value of the premium tax credits and cost-sharing reductions that would have been available to Minnesota Care enrollees had they been enrolled through an exchange. And then the state funding comes through the Healthcare Access Fund. And finally, I'll just briefly mention MNsure. MNsure is, of course, the state's health insurance exchange. It's governed by a board of directors. It has a few primary functions. One of those is, of course, to assist individuals in obtaining individual market insurance. Through MNsure, you also determine the eligibility for federal premium tax credits and the cost-sharing reductions. And you can also apply for Minnesota Care and MA through MNsure. And MNsure is primarily financed by a 3.5% assessment on the premiums of the plans offered through MNsure. And there's also some money that comes from DHS related to sharing an eligibility operating system. And with that, I'm going to hand it back over to Joe and Elizabeth.
Representative Backer, the next topic we're covering is the health-related licensing boards. I need not go through each individual licensing board and their funding here. The main takeaway for the committee is that there's 16 of them. They're funded almost primarily out of the state government special revenue fund. And while those health-related boards are able to assess fees for licensure, they're only able to access that revenue pursuant to an appropriation set forth in law. So do know that while you may hear a bill this session that increases or decreases a fee, that will impact the fund itself, but the agency needs to be appropriated that net effect in order for them to access those dollars. I'll pass it over to Ms. Clarkvist to talk about the regulation of such occupations.
Representative Backer and members, I'm Elizabeth Clarkvist from House Research. I'll start by talking about the regulation of health-related occupations. In Chapter 214 of Minnesota statutes, it says that no occupation can be regulated in the state unless its regulation is required for the health and safety and for the safety and well-being of Minnesotans. In Minnesota, health-related occupations are regulated by the Health Department, by the Office of Emergency Medical Services, and by one of 16 health-related licensing boards. Some of these boards regulate a single occupation, and other boards, like the Board of Medical Practice, regulate a range of related occupations. And this slide lists the 16 health-related occupations in the state, and for the Board of Medical Practice, it shows the occupations that board regulates. And for a more complete list, we have, House Research has a publication on regulation of health occupations, and that publication contains the complete list of boards and each of the occupations regulated. Minnesota has joined interstate licensure compacts for some of these health occupations, and those have the effect of allowing qualified individuals in member states to more easily practice their professions in other states that have also joined the compact. This slide lists the compacts of which Minnesota is a member. And it shows whether they're in effect or some of them are active, meaning the requisite number of states have joined the compact, but they're not yet operational, meaning the other behind-the-scenes work that needs to happen for people to actually practice in member states hasn't been completed yet.
Representative Backer, members, the next item is the Minnesota Department of Health. I alluded to this before. It is a considerable state agency when looking at all funds. Almost half comes from the federal government, 27% from the general fund, and a slew from the other special revenue accounts I talked about at the beginning. Current combined fund balance, all funds for the Department of Health in the upcoming biennium is $1.8 billion. Here is documenting the Department of Health base FTEs. Just one aside is these are not additive. You don't take 1873 plus 1708 and add it together. That is a number that goes from one year to the next. The committee will start processing fiscal notes, and the same phenomenon exists on fiscal notes where FTEs exist in isolation in the fiscal year reported. So in one year, it's 1,800, and the next year, it's 1,700 in total. But as you can see, there's a considerable amount of base FTEs at the department that are paid out of the multiple funds that I just mentioned. In total, in FY '26, 1,873, in FY '27, 1,708. I have the three other budget activities listed here. In your packets is a spreadsheet that's titled November 2024 Forecast, and it's dated January 14th, 2025 at 3:04 PM. Beginning on page 2 of that, there is a full accounting for the individual activities within these budget programs. Do know that this is the sum total of the overarching programs therein. This is the other slide, but just as a number, not as a percentage, just to show the considerable amount of funds. The federal dollars given to the health department include a combination of federal TANF and federal monies that account for $861 million in the upcoming biennium, and approximately $486 million are due to come from the general fund. For health improvement, one of the three I mentioned before, similar split, of $480 million come from the feds, $423 million comes from the general fund. Health protection, larger split here, federal dollars include $380 million in fiscal years '26 and '27. It has a considerable amount of state government special revenue funds of $142 million, and a much smaller amount of general fund dollars appropriated in the base of $63 million. And last but not least, you have health operations, which, consist of the commissioner's office, general counsel's office, centralized activities within the department. It receives a general fund appropriation in the base of $45 million a year. And with that, I talked very quickly about all of the budget activities, but Ms. Clarkvist will talk about some of the specific policy goals within each of them.
So moving on to activities and programs at the health department. For purposes of this overview, I've divided their activities in kind of three broad categories. And the first one I'll discuss is public health activities. These are programs that are designed to protect and promote the health of people and communities in the state. Minnesota's public health system is a partnership between the health department, local public health agencies, tribal governments, and other organizations. The health department is the state's lead public health agency, and the commissioner is responsible for maintaining an organized system to protect and improve public health, distribute federal and state money, and provide administrative and program support. The local, sorry, I was still on that one. The local entities that perform public health activities can be organized as a community health board or as a human services board that assumes the duties of a community health board. And these boards can cover the jurisdiction of a single county, multiple counties, a city, or a city and county combined. There are 51 of these boards in the state, and their jurisdictions are shown on the map on this slide. And the health department also works with tribal governments in providing public health services. For community health boards, some duties are specified in state law, and some community health boards assume other duties through delegation agreements with the state. So a wide variety of programs and topics kind of fall under public health. And this slide lists some of the things that members might learn about in the course of this session. Under each of these topics, I'll just mention a few programs to illustrate the issues that might come up. So beginning with health equity, these are programs and activities that include providing resources and support to advance health equity within the agency and statewide. Health equity staff conduct trainings for MDH staff and for grant recipients, and develop and implement programs to address health inequities in the state. Health equity programs include the Office of African American Health and the Office of American Indian Health, and distributing grants through these offices. Moving on to child and family health. These programs include things like administering grants for home visiting programs, administering WIC, which is a program that provides vouchers for healthy foods to pregnant and breastfeeding women and infants and young children, and it also provides breastfeeding support and nutrition education. Also includes administering the Commodity Supplemental Food Program, which provides food support to seniors. The Health Department distributes federal maternal and child health block grants to community health boards for programs that serve families and individuals who are high risk or are low income. And it administers the Children and Youth with Special Health Needs Program, which is a set of programs to serve children with special needs and their families. Moving on to health promotion. There are a variety of programs aimed at promoting health and preventing or reducing the prevalence of chronic disease. The Center for Health Promotion is an entity that partners with local community organizations and health systems to provide programs on healthy aging, arthritis, asthma, cardiovascular health, and type 2 diabetes. It administers cancer programs like the SAGE screening program, which provides screening for breast and cervical cancer patients. It conducts injury and violence prevention activities, including a suicide prevention program and support for the 988 Suicide and Crisis Lifeline. There are chronic disease programs, including the Minnesota Cancer Reporting System, which is a statewide program that collects demographic, diagnostic, and treatment information from Minnesota residents diagnosed with cancer. Programs in the community health area include the Office of Statewide Health Improvement Initiatives, which administers the Statewide Health Improvement Program, also known as SHIP, which is a statewide program to support local programs on wellness in communities, schools, work sites, and healthcare settings. It also administers the Center for Health Statistics, which is an entity that collects and analyzes health-related data and coordinates other health data collection work. I want to mention the Office of Vital Records. This is the office that administers the statewide system of vital records, including records on births, deaths, and marriages. And requirements exist for who must file vital records, when they must be filed, amendments to vital records, and who may obtain vital records.
Excuse me, Chair Backer, is it in order for me to ask questions at any time, or are we just going
Yeah,
through information?
Okay, we're getting close, so hold your question, and then we will ask questions at
Great.
that time.
Thank
Okay?
you.
And I invite questions because we are responsible for a large part of the budget. So but let's the nonpartisan finish and then we'll open up to questions.
Thank you.
Go ahead,
Okay.
staff, go ahead.
Chair Becker. Moving on to environmental health programs. These include programs that protect indoor air quality, such as implementing and enforcing the Clean Indoor Air Act, lead abatement and asbestos abatement, and licensing for radon mitigation. This part of the department also performs activities to protect sources of drinking water and protect and monitor public water systems, and it protects private wells. It also regulates food and beverage establishments, lodging establishments and resorts, swimming pools, and children's camps. The health department enforces the food code, and this is an activity that it performs in conjunction with the Department of Agriculture. It performs radiation safety activities, including monitoring for radiation around the state's nuclear power plants, licensing and enforcement for handling of radioactive materials, and regulation of X-ray equipment. And its climate activities include providing education, research, and technical assistance to public health professionals and the public to explain and address health impacts from climate. Moving on to infectious disease programs. These programs include collecting reports on and investigating disease outbreaks. Its immunization activities include providing immunization information and statistics, adopting requirements on immunizations for certain populations, collecting immunization reports from schools and childcare settings. In the next area, the department provides STD, HIV, and tuberculosis statistics and reports, conducts prevention activities, and conducts disease investigations and consultations to ensure adequate therapies being provided. The department also collects and compiles reports on infectious diseases, and it collects reports on healthcare-associated infections and antimicrobial resistance, and provides tools and education to prevent these. The department administers the public health lab, or it houses the public health lab. And activities of the public health lab include analyzing environmental samples, testing human specimens to detect disease outbreaks and identify trends in infectious diseases, and collaborate with hospitals and clinics to provide specialized testing. The Public Health Lab also operates the newborn screening program, which is a program that tests newborns for more than 60 rare disorders, for hearing loss, and for critical congenital heart disease. So moving on from public health, the next general area I'll touch on is healthcare regulation. And this includes regulation of certain health occupations, managed care systems, health facilities, home care providers, and investigation of complaints regarding care provided in certain facilities. The chart on this slide shows a list of some of the health professions that are regulated by the health department. These occupations can be regulated by licensure, registration, or certification. And the department investigates complaints and conducts enforcement activities and enforces consumer protection laws. In some cases, the department also regulates the setting where these individuals provide care or services, such as funeral establishments. Moving on to regulation of health facilities and providers. Health facility regulation includes licensing or registering the facilities listed and the facilities and providers listed on the slide, and enforcing laws for these facilities. The department certifies clinical laboratories. It registers supplemental nursing services agencies. It surveys nursing homes under cooperative agreement with the federal government to ensure they meet federal regulations and certification requirements. It also evaluates whether to grant exceptions to the hospital moratorium on new beds and facilities and to the nursing home moratorium on new beds, and it provides that information to the legislature. The Office of Health Facility Complaints at the department investigates complaints and enforces maltreatment laws in MDH-regulated facilities. The Health Department also has a role related to insurance. It licenses health maintenance organizations, and it regulates their fully insured health plans. The department regulates county-based purchasing organizations, which, as Ms. Mock explained, was one of the entities that can provide managed care to public program enrollees. The department also ensures provider network adequacy of HMO networks and of the networks of the health carriers that are regulated by the Department of Commerce. It administers an external complaint process for HMO enrollees in which the complaint is investigated and a determination is made as to whether the HMO action was in compliance with applicable laws and the enrollee's health plan. And the department also administers the Essential Community Provider Designation Program. An essential community provider is a provider that serves high-risk special needs or underserved populations. Finally, in the health department area, I'll talk about a couple of types of programs in the healthcare reform category. And these are initiatives and programs to improve access to care, improve quality of care, or reduce healthcare costs. And the first type of these are healthcare workforce development programs. And a goal of these programs is to ensure that there are healthcare providers available throughout the state. And there are different strategies for pursuing this. One of them is loan forgiveness. The department can provide grants for loan forgiveness for certain professionals who work in rural areas, who teach, who work in underserved urban communities, or who work for certain provider types. Another activity is grants for clinical or residency training program to provide grants for things like adding rural or underserved rotations or clinical training experiences, grants for new trainings, for new residency training slots. The department also administers the Medical Education and Research Costs Program, or MERC, and this was created to help offset lost patient care revenue for teaching facilities to cover some of the costs of clinical training for some provider types. The department administers the International Medical Graduates Assistance Program, and this program was intended to reduce practice barriers faced by foreign medical graduates and to help these immigrant international medical graduates integrate into the Minnesota healthcare system. The department provides mental health continuing education grants, and these fund the continuing education requirement costs for mental health professionals from underserved communities and helps them become supervisors. A second category is using using technology to increase efficiency, lower costs, or improve quality of care. With regard to electronic health records and health information exchange, the department maintains standards for sharing data across these systems, and hospitals and healthcare providers are required to comply with these standards. The department administers the All-Payer Claims Database, which is a database of healthcare claims for Minnesota residents, and that data can be used for purposes specified in statute or is authorized by the commissioner as long as the use serves a public benefit. And the statewide quality and reporting system, the statewide quality reporting and measurement system is also called SQUIRMS, and Under this program, the Health Department established a standardized set of quality measures for healthcare providers, and clinics and hospitals annually report on these quality measures, and the department issues public reports on trends in provider quality. And two final reform initiatives. One is care coordination through healthcare homes. Healthcare homes are certified by the health department, and they coordinate the care of high-need patients. Healthcare homes have to meet standards for care coordination, and healthcare homes can receive care coordination payments from public programs for these services. Another is the Center for Healthcare Affordability. Legislation establishing this standard was enacted in 2023, and duties include research and analysis of the drivers of healthcare spending to identify strategies to reduce waste and low-value care, reduce administrative spending, promote the provision of high-value care, evaluate growth of healthcare spending, and identify reforms to increase affordability of healthcare. And from that, we'll move on to the Office of Emergency Medical Services and the Rare Disease Advisory Council, and we're in the home stretch.
Members, first off is the Office of Emergency Medical Services, formerly known as the Emergency Service Regulatory Board. I might have mixed that up. As of January 1st, it is now the Office of Emergency Medical Services. The 24 legislature, it is not shown on here, authorized significant one-time funding to the office for Sprint Medic grants and aid. That amount is not in the base anymore. This upcoming biennium, the total general fund dollars for the office is $12,356,000, and with an accompanying de minimis other funding resources. Ms. Clarkis will talk a little bit about what they do and how they do it.
So as Mr. Harney said, the Office of Emergency Medical Services replaced the EMS Regulatory Board effective January 1, 2025. And duties of the board include licensing ambulance services, registering medical response units and emergency medical responders, certifying EMTs, AEMTs, and paramedics, approving education programs for emergency medical responders and ambulance service personnel. They administer the pilot program, the Sprint Medic pilot program, and they also distribute grants.
And next but not least is the Rare Disease Advisory Council. It receives approximately $652,000 in general fund-based spending.
And the Rare Disease Advisory Council was established in 2019 at the University of Minnesota, and it became an independent advisory council in 2022. It's comprised of at least 17 public members and 4 legislators. And its duties include developing resources and recommendations for quality of treatment and services and access to treatment and services for people with a rare disease, advising and consulting on recommendations and programs for the diagnosis, treatment, and awareness of rare disease, and advising on and advancing policies at the state and federal levels. And the last slide is the contact information for Ms. Mock, Mr. Harney, and myself, and we would encourage you to reach out to us if you have any questions about bills, amendments, fiscal notes, or health topics in general. Thanks very much.
Yeah, thank you. They put a lot of time into this, and they've been a big help here in the last 5 to 6 weeks, so thank you so much. We will open up to questions, and then one thing, just especially for the new members, if you do want to be recognized, you work through the chair. That's how we're going to do that here. Other committees are a little relaxed. We're going to be pretty strict here. So with that, I recognize Representative Dibble. Is that pronouncing your last?
DePel.
DePel. You're going to have to help me. DePel.
Yep,
DePel.
that's all right. We're all learning here.
Thank you. Go ahead,
Yeah,
Representative DePel.
thank you, Chair Backer. A couple different questions. Does the Office of Vital Records track the termination of a baby's life or abortion? And have you seen an increase in that since 2024 or since the PRO Act, rather 2022, when the PRO Act was passed?
Go ahead, whoever wants to take
Representative
that.
Backer and Representative DePel, that data is not collected through the Office of Vital Records. It's collected through a separate report that's a termination of pregnancy report. I would have to look at this year's report to get you data on how those numbers have changed, but I can do that and get back to you on that.
Thank you. And then I have a couple more.
Yeah, go ahead.
Quick ones here. In terms of the drinking water, is there assistance for cities that have PFAS contaminants in their water supply who are trying to build filtration systems?
Thank you, go ahead. Whoever can take that.
Representative Backer and Representative DePel, that might be something, I don't know if that would go through the health department or if that's through another state agency, but again, that's something I'd have to look into and get back to you on.
Okay, thank you so much. Appreciate that.
Representative DePel, go ahead.
Last question here. Under health equity, equity being different than equality, would anybody be denied service based on race, gender, political, or religious views under the equity stance? Or is that the same as equality, just semantics?
Go ahead, yep. I think-
Representative Backer and Representative DePel, I'm hesitant to speak about how the health department,
I'm sorry, I'm not trying to put you in a hard position.
No.
You've done a great job, so I'm not trying to do that.
I don't want to speak for them, but my understanding of health equity is it's more of an education component of the department and less of a provision of services component. But maybe I can talk with you separately about what additional information would be useful.
Sure, yeah, thank you. Appreciate that.
Okay,
Thank you, Chair Backer.
thank you, thank you. Other questions from other members? Okay, I guess you're off the hot seat for a little bit. Well, thank you very much. Then, members, that is what we have. Yeah, we got some time, thank you. So what we're going to do, we're going to go up to the agenda because we thought there would be more questions, so you did a great job, and so forth. So I would like to go back to the second thing on our agenda is that's members' introduction, and then staff introduction. So I know, especially for staff perspective, I know that's going to be very helpful. So Representative DePel, we'll start with you and just who you are and what area, what's the district you represent. So keep it down to about 25 seconds.
Thank you, Chair Backer. I'm Tom DePel. I'm from Hastings, Cottage Grove area, and really appreciate it. I'm sorry to put you in the hot seat. You guys did a great job. So yeah, thank you.
Representative Franson.
Thank you, Chair Backer. Representative Mary Franson, representing District 12B. The main big city there is Alexandria, the city that is easy to get to and hard to leave. And I am just so thrilled, after being off of health for 4 whole years, to be back with some of my favorite people. Thank you.
We'll take that as a compliment. Thank you, Representative Franson.
I said that nice, slow, and deliberative to make sure I was very
I thought you
kind.
represent the best.
I do.
There you go. Representative Gilman.
Yes, Representative Don Gilman, happy to be here. This is my second term. And again, I was a member that was excited. I put 1 and 2, Health and Human Services, Finance and Policy, as what I was wanting to be on, and I get to be here, and I'm excited.
Good, good, thank you. Representative Perryman.
Thank you, Chair. Got to let work this through here. My name is Representative Bernie Perryman. This is my second term. I did serve on the Health Policy Committee last time as well. Enjoyed it so much that I heard Backer was going to chair it and had to be back with it. So, and I represent 14A, which is St. Cloud, Waite Park, St. Augusta, and St. Joe. And I am also on Commerce, and I believe a lot will come through Commerce as well when we deal with a lot of things. So looking forward to working with this group and coming through Commerce. Thank you.
Thank you, thank you. And then we have Representative Help me out. Help me out.
I am Representative Scott Van Binsbergen.
There we go, I got it out, barely, thank you, go ahead.
I represent District 16A, which is Chippewa, Renville, half of Meeker, and part of Candioi County. Excited to be able to serve on the Health Committee. I'm also co-member with Representative Perryman on the Commerce Committee. So we'll look forward to serving, being part of this committee.
Good, thank you. Representative Zalisakar.
Thank you, Chair Baker, and I'm really happy we have a new backer. We have
That's fine.
yes.
I've been called Baker
Oh,
before.
I had another committee today. I'm really happy we have a new name that's longer and harder than Zalesnikar to sit next to me. So welcome to Health, and I'm happy to be at this table. I've spent my career as a licensed nursing home administrator in the purview of many of these conversations and licensing, and so I'm excited to be here. I was on Human Services last 2 years, and now this year I'll be on Health. So thank you.
Thank you. Representative Knutson.
You nailed it. Thanks,
I
Chair.
got one. I would have been 3 strikes in a row, okay? I can't do that.
It's a pretty easy one. Representative Krista Knudsen, I represent House District 5A, which is up kind of central Minnesota, but we call ourselves northern Minnesota. The area between Brainerd and Detroit Lakes. This is my first term on the Health Committee, my second term in the legislature, so looking forward to learning a lot. Thank you.
Vice Chair Nadeau.
Chair Backer, I'm Danny Nadeau. I represent Northwest Hennepin County, Rogers, Dayton, Champlin. This will be my second term on the Health Committee.
Mr. Carter. Yeah.
Members, my name is Jonathan Cotter. I am the Republican Committee Administrator.
And he's good at what he does. He does. So Representative Jeff Backer, I represent the western part of Minnesota where the hump tip elbow nose is. So my district borders North Dakota and South Dakota. And of course, I'm really looking forward for us to make some good policies. I think there's things, I think all of us who are serving on this committee wants Minnesotans to be healthier if it's through preventive care instead of just focusing on sickness. So I'm excited. We have a good team. And with that, I'm going to change it, punt it over to Mrs. Scorby. Did I do that right?
Yeah.
Oh, right.
My name is Caitlin Scorbies, and I am Chair Backer's Committee Legislative Assistant.
Representative Rapinski? Close.
Just like it sounds. Rapinski.
Okay, thank you.
Thank you, Chair Backer. My name is Aaron Rapinski. I represent District 26A, which is pretty much Winona County, southeast Minnesota. I'm a first-year legislator, looking forward to be part of the group, and excited to meet everybody and get my hands dirty. Thank you.
And not last but least, Representative Schumacher.
Wow.
Not last.
Representative Schumacher, I've served on the Health and Human Services Committee in one capacity or another for the last 15 years. By the end of this session, I will be co-chairing the Human Services Committee with Representative Knorr, I assume, will be at that point maybe, and glad to be here.
Good, thank you. Okay, seeing no further actions, I will adjourn our meeting. Our next meeting will be Wednesday, January 26th, same place from 1 to 2:45. Did I say, yeah, January 22nd, excuse me, from 1 p.m. to 2:45, right in the Capitol 120. And thank you, members. With that, we are adjourned.